So everyone heard that. This meeting is being recorded. People are still hopping on. We're still even getting people signing up, so they'll be getting the link as well. I'm going to drop some information into the chat, and then we're going to do a round of introductions, and then Abby's going to give her presentation. Yeah, okay. I'll post the info in the chat a few more times as people join. Yeah, okay. Okay, well, thank you to everyone for joining us tonight. Welcome to COVID-19 Night School. My name is Lisa. I'm an organizer for the Harvard Graduate Students Union, UAW Local 5118. I have a PhD in public policy from Harvard. So this union is the labor union representing student workers at Harvard. Okay, thank you. Someone just let me know my post defaulted not to the attendees, but to all panelists. So let me correct that. Thank you for letting me know. Okay, hope that went through. Great. So we're the labor union representing student workers at Harvard, including all graduate research and teaching assistants. Night School is an interdisciplinary series of talks for the public given by members of our union, many of whom are doing very relevant work on COVID-19 and pandemics right now. It's really exciting to see so many of you join us. We had hundreds of people who registered from all across the US and beyond. Right now we have 4 talks scheduled and more in the pipeline, so please look out for updates. And then I'll have the other 2 panelists introduce themselves. Camille, you want to go ahead?
Hi, I'm Camille. I'm also an organizer with the Harvard Graduate Students Union. I recently graduated from Harvard College as an undergrad. I studied social studies or history. And I'm also going to be on here to help monitor questions and make sure everything runs smoothly. Thanks for coming, y'all.
Cool. Hi, everyone. My name is Mark. I'm also an organizer for the Harvard Grad Students Union. I'm currently a PhD student in organismic and evolutionary biology. So the 3 of us, Lisa, Camille, myself, are going to be helping to moderate some of the questions tonight. And I want to say just a quick few words about that, about the format of the talk. So first, Abby is going to share her screen with her presentation. And if you want to ask questions during the talk, you can do that through the Q&A function, which is at the bottom of your screen. She'll be pausing a few times throughout the presentation to check on the Q&A, and she'll also be able to answer questions at the very end as well. So if you have any questions or comments not directly related to the presentation, feel free to just use the regular chat function. And one of us 3 panelists can sort of help you out, maybe if you're having audio issues or can't find the Q&A or something. And yeah, if you didn't hear at the start, we are trying to record this talk. We'll see how that works. Our goal is to upload this afterwards on YouTube. Just putting that out there so that you know we've already started the recording. And yeah, we'll email all the registrants with a link to that later this week.
Okay, so I'm going to share my screen and hopefully that'll work.
Abby, I was going to do your intro actually.
Oh yeah, of course. Go ahead.
Right.
I'll stop sharing.
Jump in on cue. But with that, I'll introduce our first presenter, Abby Schiff. Abby is from Brookline, Massachusetts. She studied molecular and cellular biology at Harvard College. She's a student in the Harvard MIT MD PhD program and is currently in her 3rd year of medical school. She has a PhD in immunology and worked on the HIV reservoir in macrophages and the impact of HIV infection on tuberculosis in the lab of Douglas Kwan at the Reagan Institute of MGH, MIT, and Harvard. She was involved in the Harvard Graduate Students Union as the immunology department representative, which is how I met her. In her free time, she enjoys music, singing, and clarinet, learning languages, art, and activism. And now I'll let Abby share her screen for her talk, From Virus to Patient, the Disease Course of COVID-19.
Okay. Hi, everybody. Thank you so much for joining us. So this is going to be a talk intended to have a general overview of some of the scientific and clinical considerations of COVID-19. So because it's a relatively short talk, much of it will be kind of high level. So the goal of this talk is to be accessible to people who have some biology background, perhaps from high school. If there are any clarifications that you need, I encourage you to write them either in the chat or the Q&A function, and there'll be some points where I'll stop and to answer clarification questions, but I will answer substantive questions after I've gone through the whole presentation. So, but please feel free to submit things to the Q&A as I go along. First, I just want to say again to thank HGSU and UAW for hosting me today. It's been a really great way to, a great voice to advocate for graduate students, and also a good way for graduate students and undergrads to come together and across departments. And this is the first talk of the COVID-19 Night School. So there are some other great talks lined up on other Wednesdays, so I hope that you'll check them out as well, including things like ancient pandemics, biochemistry of drug design for COVID-19, and some vaccinology. So just a little bit about me, as I was just introduced, but in undergrad, I spent some time researching vascular endothelial cell signaling with Thomas Michel. Then I worked with David Ho on HIV broadly neutralizing antibodies, and then my graduate research, as I said, was, or as we said, was in the lab of Doug Kwan on HIV and TB co-infection in the lung. And currently I am doing clinical rotations when we are not asked to not be on the wards, and I'm part of the Harvard MD PhD program. So this has been my journey from virus to patient care. In addition to all that work, more recently I've been working with an amazing team of medical students on a COVID-19 curriculum. So for the past month, since we've been out of the wards, we've pooled resources to put together currently 7 and upcoming an 8th chapter that cover a variety of topics, from the basic science and clinical manifestations of COVID-19 to epidemiology, the current response in the US, tips on communicating information about COVID-19, training for potential clinical roles, medical ethics, and global health, and there's an upcoming module on mental health. So as I said, this will not have a ton of details, but if you would like more information, this is all free and online, so I encourage you to check out curriculum.covidstudentresponse.org. And it's being updated every Friday. It's all being reviewed by Harvard Medical School faculty, and it's actually being used for medical education by at least 12 medical schools that we know of. So I just want to thank the co-authors on Module 1, where I got most of the, well, I contributed to and I got most of the information from. And then also just on Monday, we were actually asked to write a review of COVID-19 for Cell for the journal. And so that was posted on Monday. So many of the images are taken from that as well. So first I'll give a brief overview of the state of the pandemic. Then I'll talk about the virology of SARS-CoV-2, the virus which causes COVID-19, talk about the pathogenesis, and then I'll describe some of the clinical course and what we know so far. Talk about diagnostics, investigational agents, including therapeutics and vaccines, and then I'll touch on 2 hot topics, asymptomatic transmission and protection from reinfection. So I got this morning. I'm sure the numbers are higher by now, but as of this morning, there are more than 2 million cases of COVID-19 that have been confirmed worldwide, and there have been over 100,000 deaths in the world. Currently, the United States has the most infections, over 600,000 infections, and this has all been happening very, very rapidly. So, okay. So basically, starting in December 2019, there were some cases of pneumonia of unknown origin that were reported in Wuhan, which is a large city in China. These cases were first linked to the Huanan seafood wholesale market. And these were actually picked up by a surveillance mechanism that had been put into place after the SARS epidemic in the early 2000s. And because of that, there was a process which sprung into action, and the causative virus was isolated and characterized in January 2020. As of January 30th, 2020, the World Health Organization declared a public health emergency of international concern. On February 11th, the World Health Organization named the disease Coronavirus Disease 2019. So that's where that acronym COVID-19 that you've probably been hearing a lot of comes from. And the virus was named Severe Acute Respiratory Syndrome Coronavirus 2, or SARS-CoV-2, because it's pretty closely related to the coronavirus that causes SARS. And on March 11th, 2020, as the virus spread beyond China and to all continents, except for Antarctica, the World Health Organization formally declared COVID-19 to be a pandemic. So the virus that causes COVID-19, SARS-CoV-2, is in the Coronaviridae family, and it's in the genus beta coronavirus. And it's one of 7 human coronaviruses. So there are a lot of coronaviruses that are known to infect other types of animals, including birds and some mammals, other animals. But 4 infect humans, and 7 infect humans. 4 cause mild seasonal upper respiratory infections, and so that's the second most common cause of the common cold. And 3 have been known to cause severe disease, including SARS-CoV, which causes SARS, MERS-CoV, which causes Middle East Respiratory Syndrome, and SARS-CoV-2, which causes COVID-19. The closest known relative to SARS-CoV-2 is a bat virus. And multiple lines of evidence suggest that there's been zoonotic transmission, or transmission from wild animals to humans, and not seeding from a lab or another source. So there are multiple mutations which are not found in any of the lab strains that people had been working on, but had been found in wild animals. However, it's unclear if the virus first went through another intermediate host. One that people have been looking at is called a pangolin, which is like an anteater, but so far I don't think that question is clear. So based on mutation rates and the most recent common ancestor, it's estimated to have jumped into humans sometime in November 2019. So the virus is a positive sense, single-stranded, enveloped RNA virus with a helical capsid. So I'll break that down for you. So it's an RNA virus, which means that the genetic material is RNA, not DNA. And you may recall that DNA is a lot more stable than RNA, but RNA can be turned directly into protein. So it's a single-stranded RNA virus, which means that it only has 1 strand of RNA, not 2 that are next to each other. And it's a positive sense RNA virus, which means that RNA can be used directly to make proteins rather than needing to be made into a new copy, which has the base paired bases. And in order to make new copies of itself, coronaviruses use an RNA-dependent RNA polymerase to make more viral RNA. So that's a type of protein that human cells don't have. And generally in human cells, DNA can turn into RNA, and then RNA can turn into protein. And it's not common to turn RNA into more RNA, and so the virus needs to bring its own protein to do that. And that's actually a target of some drugs. Some of the structural proteins in the virus include S, E, M, and N. So S, or the spike glycoprotein, is important for binding to the receptor and helping the virus fuse with the host cell. And it's targeted by host neutralizing antibodies. There's also 2 other components of the viral envelope, including envelope protein, or E, which is important for virus infectivity, and matrix glycoprotein, or M, which it also interacts with E to form the viral envelope. And then the final structural protein is known as N, or the nucleocapsid protein, which wraps around the viral RNA and helps provide the structure. So in terms of viral replication, the viral spike protein, or S, binds to a protein on the outside of the target cell called ACE2. ACE2 is an enzyme which is involved in the renin-angiotensin-aldosterone system, which is an important pathway that maintains blood pressure and fluid balance in the body. But in this case, it serves as a receptor for the virus. When S binds to ACE2, then S is cleaved by a host serine protease known as TMPRSS2, which then allows the spike protein to allow the virus to enter the cell. And there are 2 pathways that this is thought to happen through. One is endocytosis, where the host cell basically forms a bubble around the virus and brings it into the cell, and then the virus fuses with that membrane and enters the host cell cytosol. and then the other is direct fusion at the cell membrane. After the RNA has entered the cell cytosol, there's translation. So ribosomes bind to this RNA and can make proteins. And it makes polyproteins, which are then cleaved into the structural proteins and also some non-structural proteins, which are important for the virus function, such as the RNA-dependent RNA polymerase. And then this RNA-dependent RNA polymerase makes more RNA copies of the original viral RNA, which then assembles with the viral proteins in a part of the cell called the Golgi apparatus, and then those are released from the cell. So there are various drugs which can target some of these different viral steps, which I'll then get to in a later part of the presentation. In terms of the cells that are targeted by this virus, the most frequent cell that people think is very involved in the pathophysiology is a cell called the type 2 pneumocyte in the lung. And those are cells that are important in making surfactant and dividing to make new lung cells. But it's also been seen to infect cells in the nose, mouth, throat, small intestine, heart, kidney, vessel endothelium, smooth muscle, and maybe others. And the significance of entry into these cell types is still being debated. Maybe not all of these cell types may actually host active replication, but it does seem like many of these cell types and many of these organs are affected in some individuals who have COVID-19, and so that may be behind some of the pathology. So as I said, it can enter either by endocytosis or fusion, and I've gone over these steps. So once somebody's infected, then they can infect other people, and this transmission occurs mainly through respiratory droplets. Large respiratory droplets are more affected by gravity than small respiratory droplets. So the large droplets have more of a ballistic trajectory, and the distance that they travel is thought to be between 3 and 6 feet, which is why there's this 6 feet guidance on how far you should stand away from people. And these droplets can be generated while talking, coughing, or sneezing. One sneeze is thought to generate about 40,000 droplets. One cough can generate 3,000 droplets, and talking can release 600 droplets per minute. So even in a 5-minute conversation with somebody, it's like they coughed on you once. So the smaller droplets which are generated can go further, and either small or large droplets can deposit on surfaces. And then if somebody touches that surface and then touches their mouth, nose, or eyes, then they can get infected. And so that's called the fomite route of transmission, which is why it's recommended to sterilize surfaces that people have been around. And so it's thought that SARS-CoV-2 may be aerosolized mainly through medical procedures. These can include intubation, which is required to put somebody on a ventilator. Also when someone's wearing a high flow oxygen mask or using breathing aids such as CPAP or BiPAP, receiving nebulizer treatments, or getting bronchoscopy. There's still some active debate about whether there can be aerosolization during talking, coughing, and sneezing as well that might hold virus. So be on the lookout for literature about that. And it can linger on surfaces for several days and spread when someone touches their face. And importantly, people can transmit virus prior to symptom onset, and some infected people never get symptoms. So just having people who have symptoms self-isolate is not going to be enough to stop transmission. So live virus has been detected in the throat. So the nasopharynx is the throat behind the nose, and the oropharynx is the throat behind the mouth. It's also been detected in sputum or spit and stool or saliva. And so far, there hasn't been strong evidence of fecal-oral transmission, blood-borne transmission, or mother-to-child transmission. It has been shown that cats can transmit SARS-CoV-2 between each other. And the length of time that the virus is infectious on various surfaces depends, of course, on the surface, but also the temperature, relative humidity, and the dose of the infectious particles. Some studies that have been cited a lot include this one where they aerosolized SARS-CoV-2 and found that the virus was viable for up to 4 hours on copper, 24 hours on cardboard, and 72 hours on plastic and stainless steel. And so the data is here, it's in red, the blue is SARS-CoV-1, which is which causes SARS. But you can see that it lasts for a while on stainless steel and plastic. So to prevent transmission, as I said before, this is an enveloped virus, and so the envelope is made out of a lipid bilayer which is derived from the host cell. And that can be broken down by soap or alcohol-based hand sanitizers, which is where the recommendation to wash hands frequently comes from. And then, as I said, staying at least 6 feet away from others comes from that ballistic trajectory of the large droplets. And of course, staying home decreases your exposure to others. And then homemade or surgical masks aim to stop transmission of the larger droplets by the mask wearer, and fit-tested N95 masks can provide better protection against smaller droplets and aerosols spread by others, as well as blocking transmission. So I'm just summarizing some of the literature on mask efficacy that I was able to find. So one study showed that surgical face masks stopped detection of the milder human coronaviruses, not SARS-CoV-2, but they only looked at RNA, not infectiousness. And they found a decrease in larger droplets and aerosols when someone was wearing the face mask if they were hospitalized. But it was a quite small study. Another study showed that homemade cloth masks stopped large droplets produced during speech by healthy volunteers. And then another study looking at coughing COVID-19 patients who were hospitalized in South Korea showed that neither cloth nor surgical masks decreased SARS-CoV-2 RNA. However, there were only 4 patients in this study, and there were some technical issues with it. So I would say the literature really doesn't have a great consensus on this yet, but the current CDC recommendations are to wear cloth masks in public and to save N95 masks for people with high levels of exposure, including healthcare workers and other people who are highly exposed to COVID patients. So I'll just talk about the immune response and then pause for clarification. So in terms of the immune response, what we know mainly comes from studies of SARS and MERS, where there have been animal models and time to really do better studies of what's going on. So if COVID-19 behaves similarly to SARS and MERS, people with mild cases likely have an early antiviral response, which would be done in response to viral components by the first cells that contact them. And then those cells produce a cytokine called interferon, which then alerts the infected cell and also neighboring cells. And if the infection gets big enough, it can alert the whole organism or the whole person that there's a viral infection going on. And it helps mobilize an adaptive immune response, which is made up of T cells and B cells, as well as other cells. So T cells can be CD8 T cells, which are killer T cells, or CD4 T cells, which are helper T cells. And of course, I'm generalizing a lot here. And then hopefully this leads to viral clearance. However, in severe cases, at least if it's similar to SARS and MERS, it seems that there may be a delayed antiviral response due to delayed antigen presentation and delayed activation of this interferon signaling. Then there may be an increased or inappropriate activation of the adaptive immune response. It's often associated with a high viral load and increased antibody titers, but at the same time, there are often low numbers of circulating T and B cells, which is a condition known as lymphopenia. And then if it keeps going in the wrong direction, then there can be a late innate inflammatory response called a cytokine storm, which is associated with things like vasodilation in the lung and release of fluids and proteins and lots of inflammatory cells into the lungs, which of course compromises lung function. So some of these components are being targeted by some drug compounds, which I'll also touch on later. So antibodies are important thought to be important in protection, although once again, we're still in early days of learning about this disease. One thing that we do know is that the production of antibodies takes about 2 weeks after symptoms start. So IgM antibodies, which tend to come up a little earlier, take a median of 12 days to be detected, and IgG antibodies take a median of 14 days after symptoms start to be detected. There's some data from SARS that suggests that some types of antibodies may make the disease worse through activating macrophages, but that's still not clear with COVID-19. That phenomenon is called antibody-dependent enhancement. So we don't know whether that's the case. It is clear from studies of SARS and MERS that CD8 T cells are important in viral clearance, but are also associated with lung damage. And these are the killer T cells. Helper T cells, or CD4 T cells, are most associated with good outcomes when they're polarized to the Th1 subtype, and the Th17 profile may be harmful. If you know immunology, you'll get what I'm saying. Otherwise, more detail than I'm going to go into today. And the depletion of these white blood cells, like B cells and T cells, may be due to bone marrow suppression, which basically means that the cells that make new blood cells in the bone marrow may not be as productive, which often happens in viral infections. But there's some suggestions in SARS and MERS that there may be destruction of lymphoid tissue and even direct viral infection and depletion of these cells. So this would be basically an abortive infection that would lead to cell depletion. And I think we still don't know enough about this in COVID-19. So I'm going to stop there for a moment and just see if there are any clarification questions. Moderators?
Yes, there's 4 questions in the queue. The first is definitely the most important. Can you see the Q&A, Abby?
Yes, I can.
Okay, great.
Okay. I think, oh, interesting. I think some of these are going to take a little longer to answer, so I'll just say, what is the mechanism of virus inactivation on surfaces drying out? I would say I don't know the answer to that. It does seem that UV light, heat, and also hydrogen peroxide, other things can directly kill the virus, but but I don't know whether drying out would kill it. It is an enveloped virus, and so if somebody else has an answer to that, then I would welcome their input as well. And otherwise, so I'm just going to say answer live and done for that one, but I certainly welcome input from the many knowledgeable people in the chat. Okay, in the meantime, I will save the others until later. So for clinical presentation, the fever is the most common symptom, but only 44% of patients had a fever at time of diagnosis. So in a large study of Chinese patients, 88% of patients had fever at some point during their clinical course, but the absence of fever doesn't mean somebody doesn't have the disease. The next most common symptom was a dry cough found in 2/3 of individuals, then fatigue, then sputum production like coughing up phlegm, then difficulty breathing or dyspnea, myalgias and arthralgias, which are achy muscles or joints, sore throat, headache, chills, and then relatively rare are nausea, vomiting, nasal congestion, diarrhea. And then in some studies, difficulty smelling has been found in 30 to 40% of people, along with difficulty tasting. So sore throat and nasal congestion are less commonly seen in COVID-19 than in other similar viral respiratory infections, but if somebody has a sore throat or nasal congestion, it certainly doesn't rule it out. And also people can be infected by more than one respiratory virus at once. In addition, children are less likely to have severe symptoms than adults and tend to have lower fatality rates, but it does seem so far like they can be infected and they can be infectious. It's just they tend to have fewer symptoms. So the disease tends to progress in stages. The average incubation period after someone is exposed is 4 to 7 days, where they may be completely asymptomatic. After that, they may end up with a fever and cough. Some people never become symptomatic, but those who do may end up just having a fever and cough for 5 to 10 days, and then it may go away if they have a relatively mild course. But in some other people, after 5 to 10 days, it may worsen, and as the host immune response kicks in, and at this point, the viral loads often tend to go down somewhat, although in some cases they don't. And this is where the more severe complications can come into play, including acute respiratory distress syndrome, sepsis, and organ failure. And people who have a worse clinical course tend to have elevated inflammatory markers. And then for those who end up with enough respiratory distress that they need to be supported on a ventilator, then they may need that, and some percentage of them go on to actually die, although some do recover. Once again, in a large Chinese cohort, 81% of individuals had a mild or moderate course, 14% had a severe course, 5% had a critical course, and the mortality rate was 49% in critical patients, but 0% for the other subsets. So most people do end up with a mild or moderate infection, but it can get severe. An organ injury may include, as I said, ARDS, or acute respiratory distress syndrome. And there, the air sacs that perform gas exchange, or alveoli, become filled up with fluids and proteins and inflammatory cells. And as you can imagine, if there's not much air, then it's hard to get oxygen into the lungs. There's also sepsis, which is basically a systemic inflammatory reaction, and often triggered by bacteria in the blood. Shock, which is a collapse of blood pressure. Kidney failure, hypercoagulability leading to blood clots and sometimes pulmonary embolisms. Heart injury, including things like myocarditis and arrhythmias. Muscle injury, such as myositis. And neurological injury, such as encephalopathy and other neurological phenomena, liver injury, and intestinal injury. So, of course, the percentages of these differ depending on location, and many of these are still being studied actively. In addition, if somebody's on the ventilator, as I said, they may do well, but the recovery after they get off the ventilator may take a while, and the long-term effects on lung function have not been well studied yet, perhaps due to the fact that this has been such a quickly progressive pandemic. So for clinical management, of course, please contact your doctor if you have symptoms or you think you may be exposed. This table is not medical advice. I have a PhD, but not an MD at this point. But just to give you a general overview, mild cases may have symptoms including subjective or low-grade fever, dry cough, as I said, muscle aches, nasal congestion, headache, or sore throat. And generally, people will be asked to have a 14-day home quarantine from the day of exposure if known, or day of symptom onset if they don't know when they were exposed. And then they're basically encouraged to seek medical attention if they get worse. While at home, it's important to keep eating and drinking and use Tylenol for comfort and fever. I think the jury's still a little bit out on use of NSAIDs such as ibuprofen, Advil, Aleve, other medications like that. But the advice is still to mainly rely on Tylenol for fever control. However, if somebody who's at home because of a mild course starts having trouble breathing, persistent pain or pressure in the chest, new confusion or inability to arouse them, or bluish lips or face, then call 911 and contact your medical provider. And for more information, you can visit the CDC site. So a moderate course might involve higher grade temperatures, shortness of breath or trouble breathing, signs of pneumonia, chills, or profound fatigue. In this case, once again, contact your provider. And in this case, it may be appropriate or not, depending on the severity, to be in the hospital. And it may be important to have oxygen to help with respiratory support. In a severe case, this may progress to more shortness of breath, low oxygen saturations in the blood or hypoxia, and then some clinical correlates of acute respiratory distress syndrome. And so this may require sort of more respiratory support, such as being put on a high flow or more respiratory support like a ventilator. And in critical cases, there's a collapse of blood pressure and signs of organ failure. And so in that case, the person would need to be in a situation where their blood pressure could be monitored, like in an ICU. They may need to be on a ventilator as before, and they may need to get medication to keep their blood pressure at a level where it can supply their organs. So age is associated with increased COVID-19 severity and mortality. Some modeling suggests people of any age can get infected, and there's mortality even in younger age groups, although at a lower level. So just because somebody may be young doesn't mean they can't get it and spread it to other people. Comorbidities or other medical conditions are often associated with increased severity of COVID-19 if somebody does get infected. And these include respiratory disease, and that includes things like asthma, chronic bronchitis, emphysema, other things like that, cardiovascular disease like a history of heart attacks or heart failure, hypertension, which is high blood pressure, diabetes, cancer, kidney failure, or people who are immunocompromised for whatever reason, whether that's because they had a transplant, they're on chemotherapy, maybe they have untreated HIV, or they're taking a medication which may affect their immune system. And so the mechanisms are still being studied as well. So I'll take another break to take a look at the Q&A. Seems like we have more questions. Yeah, there's a question about whether mild and severe cases are dependent on how many viral particles infect the person or the person's immune system. So I have not encountered a clear answer to this. I've seen in some discussion online that people are thinking that the amount of exposure may be important, but I haven't seen any particular studies for that. I certainly think the immune system is quite important, and that's seen in the susceptibility of people with comorbidities who may have some immune defects. Okay, could you go into more detail into surveillance? I'll talk about that later. I will be talking about asymptomatic people transmitting the virus later in the talk. Current hypotheses about why children have less severe symptoms, I'll go into later. Yeah, a lot of these I'm going to go into later. So age 8, that's nice. Okay, I think I will answer most of these later. Okay, so now I'm going to move on to diagnostics. The most common diagnostic test involves looking for viral RNA. And most of the virus, at least in early stages of infection, is replicating in the respiratory tract. And it's thought to start like in the upper respiratory tract, so in the nose, mouth, and throat, and then progressively move down into the lungs over that first 5 to 10 days. So if somebody is being tested, then it's important to put a swab to where the virus is. And so there's a large swab which goes in through the nose or through the mouth and scrapes the back of the throat. And if you end up with that, I've heard it's a little uncomfortable, so just be prepared. And then that swab is used for RNA extraction, and then that goes through a process called reverse transcriptase polymerase chain reaction, or RT-PCR. And this basically first turns the RNA into DNA, which is more stable, and then uses primers which bind to specific sequences found in SARS-CoV-2, but not other coronaviruses and not other viruses, and amplifies the regions that are specific to that. And that's done in a quantitative way so that it's possible to measure how much virus there was in that sample. So this was developed first in January, and the World Health Organization disseminated a protocol and reagents to different countries around the world. And the United States opted to use a test developed by the CDC, as is their general policy to develop a CDC test. Unfortunately, this ran into technical problems, and there was a time in February when tests could only be performed by the CDC, and so that kind of slowed down the progress of testing in the United States. And now, unfortunately, there seem to be some reagent shortages, which is complicated by the fact that people around the world need to be running this test. RT-PCR tests can be performed multiple at a time, but they require lab facilities. Another type of test that is being developed is called an isothermal nucleic acid amplification test. So this can deliver results in about 15 minutes, but it can only run one test at a time. And they come in these cartridges, which are a little expensive. They can be performed at the point of care. So for example, if there's a drive-through testing facility or a pharmacy. But once again, you can only run one test at a time. And a company called ID Now received an FDA emergency use authorization, or EUA, a few weeks ago. There's also some tests based on the CRISPR technology that are under development. CRISPR, you may have heard about. It's a system that uses a sequence of nucleic acids to cleave at a particular area. And it came from a bacterial defense system against viruses. So two platforms that are developing tests for COVID-19 are called Sherlock and Detector, and they could have results in about an hour, but neither of those has been gotten an EUA from the FDA. So two other strategies that could be used, which can look for slightly different information, are antibody detection and viral protein detection. So antibody detection looks for antibodies in the blood against COVID-19 proteins. So as I mentioned before, it can take 1 to 2 weeks for these antibodies to appear. So if somebody's tested shortly after they were infected, it may be a false negative. but the antibodies should remain after infection for a period of time. So that should be able to detect whether somebody was previously infected, even if their RNA test is negative. So this can detect IgM and/or IgG antibodies to COVID-19 proteins. These tests are performed on blood samples, and they often use rapid point-of-care lateral flow immunoassays, which look something like this. So you might put a blood droplet like a finger stick here, and then a line will appear as the control, and then other lines will appear if there are antibodies to COVID on the test. And Cellex, which is a company, received an EUA at the beginning of April. So another technique which might be helpful as well is to look for viral proteins. So this may have a similar timing to nucleic acids, but there may be different sensitivity, and it might be a good way to do 2 different types of tests on the same person, so you don't have false negatives or false positives in the same way. But currently that's under development. So now moving on to therapeutics. So I'm hoping to walk back through this viral replication cycle that I talked about before and highlight which steps are being targeted by therapeutics in trials. When SARS-CoV-2 is trying to enter a cell, there can be antibodies that bind the spike protein or S protein and prevent the virus from binding to ACE2. And this can be targeted by custom-made monoclonal antibodies, which are in development, or convalescent plasma. So taking blood from somebody who's already recovered from COVID-19 and giving it to another person. There is also an inhibitor of this protease that's in testing called camostat mesylate. And then with the endocytic pathway, there needs to be acidification of the endosomes in order to have fusion, and that acidification is inhibited by chloroquine and hydroxychloroquine, which you've probably heard about in the news. And then the protease inhibitors, lopinavir and ritonavir, which have been used for HIV, can potentially prevent the breakdown of these polypeptides into their component proteins. And then there are a few inhibitors of the RNA-dependent RNA polymerase, such as remdesivir and favipiravir. And those are the steps that are being targeted, or the major steps that are being targeted. So camostat mesylate, I think, is being studied, but I haven't seen any studies that have come out yet. Lopinavir ritonavir had a randomized controlled open label trial, which did not show any benefit, but in a subset of patients who received it early, did look like there might be some benefit, but it was not significant. So there are other studies that are underway that we'll be reporting soon. Remdesivir, which is this RNA-dependent RNA polymerase inhibitor, recently published one case series, which looked somewhat promising, but there was no control group, and there's no clinical trial data yet. Favipiravir is approved to treat influenza in Japan, and as far as I know, there's no clinical trial data released yet. And chloroquine and hydroxychloroquine had some early promising data, and so they got an FDA EUA due to that. However, one of those initial papers was retracted by the journal, and then since then there have been at least 2 other studies that have come out that have been more mixed. One that suggested that actually the patients did worse, and another that showed no benefit but showed many more adverse events in the patients who were on these drugs. And that's partially because of an impact on the heart called QT prolongation. So I think that this is not necessarily the wonder drug that it's been thought to be. Another potential thing would be combining one of these drugs with azithromycin, and I think the jury's still out on that as well. So there's also anti-inflammatory drugs, and these drugs are, the target is the immune system in people who progress to severe disease. So the thought is that it's good to have an immune response early, but there can be an overreaction in the people who get severe disease. So the go-to drug to calm down the immune system are steroids. And these have many side effects, but usually work pretty well at calming down inflammation. But interestingly, they may actually be harmful. And so that's kind of mystified people a bit. However, some more targeted anti-inflammatory therapies may have more efficacy, although once again, we don't really have clinical trial data on these yet. There are 3 antibodies that all target the IL-6 receptor called tocilizumab, sarilumab, and ciltuximab, and that's primarily on T cells. So there's a case series for tocilizumab, which looks nice, but once again, no control group, and we don't know if the patients would have done okay on their own. And there are multiple clinical trials underway. And then there are some trials targeting IL-1 and some other immune targets. Also, as I mentioned, there are some antibodies against the virus. There are some monoclonal antibodies in development, and convalescent plasma, which is, as I said, taking antibodies from people who already recovered, was authorized by the FDA for this experimental treatment in March 2020, and two pilot studies with small numbers of patients showed improvement, once again, without a control group. And without a control group, it's very hard to evaluate the efficacy. So just as a summary, the Infectious Disease Society of America, or IDSA, released clinical guidelines this past weekend, and in them they say clearly there have been no satisfactory randomized controlled trials to advocate for any targeted therapy of COVID-19, and any of these drugs are authorized in the setting of a clinical trial, because the hope is to really study them more systematically so that we can really know what works. Unfortunately, that does take time, and it's hard with so many patients in the hospital to not know what works. So moving on to vaccines. We're really hoping for a vaccine so that we can sort of allow social interaction again and be able to protect people. So there are a variety of different vaccine strategies that target various parts of the virus. So there are some mRNA vaccines, which basically take some of the sequences for proteins, although not the whole virus, and then put them into a person so that the person's cells can make viral proteins, and then that will lead to an immune response. And I think this is the one that started the earliest. So Moderna, which is a company in Cambridge, started a phase 1 trial in mid-March. And then DNA is similar, but it basically uses DNA with viral proteins to make the host cells make viral proteins. And there's one in development in a phase 1 trial. There are several chimeric vaccines which take some viral proteins and put them either onto another virus that doesn't cause harm, or nanoparticles, or some other delivery method. And there's 2 in phase 1, and there's 2 preclinical ones that I know about. There are also some subunit vaccines which take viral proteins. There's a preclinical one. Some take the whole virus and either kill it or inactivate it, and there's one in development with Johnson & Johnson. And then for a different type of approach, people have observed that in countries that vaccinate their population with a TB vaccine called Bacillus calmette-guerin, which is Mycobacterium bovis, seem to have somewhat, well, potentially lower mortality from COVID-19, although of course it's not super lower because people around the world are getting infected with this. But there is a thought that maybe this calms down the inflammatory response to COVID-19. So people are trying clinical trials with healthcare workers and elderly people to see if this would help, even though it's a totally different organism. So for more detail, you can look at Module 3 of the medical student COVID-19 curriculum. So now I'm going to transition to the 2 hot topics. I'm just going to take another moment to just glance through the Q&A, but remember, I will have more time to address it later. Let's see. Sorry, there's many questions. One quick thing, will we be able to access the slides after this? Yes, I will provide the slides. And there's some which I will still answer. Yeah. So also, I'm not an expert in all of these things. So for some of them, I may need to defer to other people or to maybe read up on them more. But I will continue with asymptomatic transmission. So studies suggest that someone can be infectious before they are symptomatic, as I said before. So it's estimated that many of the new COVID-19 cases were spread by people who showed mild or no symptoms of disease at all. So this paper in Science suggested that almost 80% of COVID-19 infections were due to contact with somebody with no or mild symptoms. And then another study estimated between 48 and 77% of new infections in Tianjin, China, and Singapore were due to asymptomatic or mildly symptomatic individuals. And so people can detect viral RNA in people, and even infectious virions in people who have no symptoms, and also at least 24 to 48 hours before symptoms begin. And in addition to that, viral RNA is detectable for quite a long time after symptoms start. So one study found between 20 and 37 days after symptoms begin. And in many cases, this lingers for a long time after people stop having symptoms. So one example where this has come up, at least from what I've heard from clinical colleagues, is that many nursing homes or rehabs are not accepting patients who still have a positive COVID test. And then people are improving in the hospital and their clinical course is going well, but they may still have a positive COVID-19 test for many days or sometimes even weeks after they seem to be better. So it's still unclear whether those people are infectious, and I haven't seen any studies addressing that yet. So of course that will be important to know. The current CDC guidance is to stay at home and self-quarantine for 3 days after symptoms disappear for people with milder cases of COVID-19. So for all of these reasons, both because people may not have symptoms yet, may not have symptoms or at all, or they may still be infectious after they were sick, social distancing and precautions are very important because many people may be infectious and will not know that they need to self-quarantine. So also another hot topic is protection from reinfection. So it's unknown if someone who recovered from COVID-19 is protected from a second infection and how long that immunity lasts if it does exist. So it's known that immunity to seasonal coronaviruses, those for milder coronavirus, lasts at least a year, but it seems to wane over time. And there have been cases of people getting infection with the same virus, which isn't even genetically very different at all, after only 2 or 3 years. And it seems like people can get repeated coronavirus infections over the course of their lifetime. And that's quite strange, but it's actually common with many respiratory viral infections, especially the milder ones, that somehow the immune response is just not that durable. So the immunity to SARS and MERS lasts at least 2 to 3 years, but over that period of time, the antibody neutralizing ability decreases. And because both of those epidemics have not been as pervasive as COVID-19, we don't really know whether people can be reinfected because they haven't affected the same people multiple times. And unlike with influenza, reinfection is not primarily due to viral mutation, but instead to problems with immune recognition of the same virus. So there have been some recent cases in the news of reinfection in South Korea, but some people think they may be explained by false negative tests or reemergence of an existing infection, especially, as I said, that there can be this long tail where the virus viral RNA can be detectable even after symptoms disappear. And a study looked at some patients in depth that seemed to have a negative test and then a positive test, and using a more sensitive test of the negative tests, they were able to find virus there. So I think that's still in question. There have been at least 2 studies looking at infection of monkeys, rhesus macaques, and these were infected with SARS-CoV-2, recovered, and then were infected again, but only a couple of weeks to a month afterwards, which of course is only, we can't really look at longer stuff yet because it hasn't been around for that long. And macaques were protected from repeat infection, but that was pretty soon after the first infection. So I think this is a very important question. And the duration of immunity will determine whether we get good and lasting herd immunity if enough people get COVID-19, the likelihood of success of a vaccine, and also potentially the vaccine may work, but people may need to get it every year or once every 2 or 3 years. It's kind of like the flu vaccine, but for a different reason. So in conclusion, there are many open questions, as you can hear. The pace of discovery is unprecedentedly fast, but good quality studies take time, both in basic science and in clinical research. And in order to exit this crisis, we need to know how to prevent transmission while allowing more in-person interaction, how to treat people with severe disease, how to prevent people with mild disease from progressing to severe disease, how to scale up diagnostic testing, which vaccine strategy will work, and then also whether prior COVID-19 infection grants immunity. And I hope that I've convinced you that understanding the journey from virus to patient is important to help us get to these answers. And I hope that when you guys are looking at the news every day, that you'll have a better understanding of what's going on. So now I will be open for actual questions. So I encourage you to keep adding questions to the Q&A, and I'm going to open the Q&A now. So thank you, Jeff. So Dave Spiegel, do you think that the 4 human coronaviruses that cause common colds used to cause SARS-like illnesses 10,000 years ago or whatever when they first entered the human population, and they affect us only mildly now because we are the descendants of the survivors? That's a very interesting question. It does seem for HIV, which I know more about, that actually seems to have been the case for some of the monkey hosts of the simian immunodeficiency virus, that essentially there's a population bottleneck, and the monkeys that could live with, that survived having SIV infection survived, and the rest of the population was killed off. So I don't know the answer to that for coronaviruses. So I read in a non-scientific but fact-checked source that infected cells can express S protein on their own surface, slough off, and directly fuse with uninfected cells to spread the infection. I haven't heard of this mechanism before. Do you know if it's true? And this is a question from Zeke Benchurim. I have not seen that. There's a lot of literature out there, and I don't know that type of mechanism where you can have cell-to-cell transmission. Once again, I know more about HIV that can happen, so I don't know, but it's certainly something that can happen with viruses. Yemi Jagede says, antibodies are current COVID-19 tests based on antibodies. How does antibody tests compare to the currently available methods? Is there any country in the world providing antibody-based tests? Thanks. So I hope I answered at least some of that in the diagnostics section. But currently, the most common test is the RNA-based test, or the RT-PCR test. As I said, in the United States now, there's this FDA provisional approval for one antibody-based test, but I don't think it's been rolled out widely yet. And it has been used more extensively in several countries. I think South Korea is using it a lot. And I think they're using it as well in some studies in other parts of Asia and Europe. So yeah. John Toms says, could you go into more detail about what type of surveillance mechanisms were in place in Wuhan that caught this initially that you touched on? So for that, I would reference the original paper that I took that graph from. Let's see if I can get back to it. But essentially, it was looking for pneumonia of unknown origin, and that included basically testing negative for other viral illnesses, not improving with an empirical antibiotics after 3 to 5 days, and having a low white blood cell count, or not just white blood cell, a low lymphocyte count. And that's something that's shared between both SARS and COVID-19, luckily, but it might have picked up other types of pneumonia as well. So here I would just reference the Lee et al. Paper from the New England Journal from 1/29/2020, which describes that. So how, Dora Sari says, how asymptomatic people transmit the virus through small droplets when they are talking. If so, how infectious asymptomatic people really are. I hope I also touched on this. It's not totally clear, I would say. I don't think there have been rigorous studies of this yet, but I think the idea is that you can create both large and small droplets potentially during talking. And so that may be how it's being transmitted, but I think the rigorous studies are not necessarily there yet. Okay, Christine Goldrick asks, what are the current hypotheses about why children have less severe symptoms than adults? Yeah, this is an interesting question because in influenza, as you may know, especially pandemic influenza, especially babies and children are susceptible as well as older people, and that's a pretty different distribution than what we have with COVID-19. So I think that's still being studied. I mean, my guess is it would have something to do with, the immune system, but beyond that, I don't know, but I think there's been more work on that I'm not aware of. Okay, 31 more questions. Actually, I don't even know what time it is. What time is it?
It's 9:30 right now.
Okay, so I still have plenty more questions I can answer. I would encourage anybody who wants to leave. I mean, I'm not stopping you. And I want to thank everybody for coming. I will continue answering questions for some period of time. And I hope this has been informative for you guys, and we'll be making the recording available after this as well as the slides.
Yeah, thanks to everyone who has to hop off now. This has been really great, and your questions are also greatly appreciated. And thanks for helping us work out some of the technical kinks which we're encountering for the first time. Yeah, thank you.
Oh, thank you guys for also answering some of the questions in the chat. I'm sorry I couldn't really see this. Yes. Thank you, Carolyn, and whatever. I'll take a look at this later.
Yeah, and yeah, for folks who are hopping off, we're back next Wednesday evening for the second night school class on pandemics in the ancient world, given by Henry Gruber. And yeah, keep checking back for updates.
Great.
Quickly, just so that you know, Abby, 2 questions that have been popping up in chat. Camille has been hopping off really quick and adding them to the Q&A stack, so there shouldn't be any outstanding ones in chat.
Thank you guys so much. I really appreciate it. Okay, so back to the questions. So Damra Kamat says, how long do symptoms persist for moderate patients? Also, after symptoms have resolved, can patients still be infectious? A recent study done in Shanghai has shown that some recovered patients have tested positive. Is it possible for the virus to reactivate? So I think I touched on some of this before. How long do symptoms persist for moderate patients? I guess I'm going to say generally maybe 5 to 10 days, but it can be longer. That's from a general sense. I'm sure there are actual studies on this. And then how after symptoms have resolved, can patients still be infectious? I think they can certainly be positive for RNA. So far, I don't quite know whether it's infectious or not, but certainly RNA is detectable. And that would be consistent with this study that shows that some recovered patients have tested positive, and I don't know whether it's possible for the virus to reactivate or not. What is the correlation? Oh, Sharik Syed says, what is the correlation between viral titer for asymptomatic versus symptomatic patients? Yeah, so it seems, at least for people with mild cases versus severe cases, it seems like severe cases tend to have a higher viral titer than the mild cases. In terms of the asymptomatic cases, there was a study in Germany, I think it's Wolfel et al., that looked at a cluster, one of the early clusters of COVID patients where they did case tracking, and they looked at people who were asymptomatic or had quite mild disease. And many of these people were shedding infectious virus in their nasopharynx and oropharynx. But it didn't actually, in that study, viral titer did not correlate with symptoms. So I don't know how well that generalizes across everything, but they certainly were able to detect infectious virus in asymptomatic people. So is it, an anonymous person says, is it possible for people who have recovered to get reinfected? I hope that I address that. I think the answer is we don't know. If it's similar to macaques, then if it's within a few weeks to a month, probably not. But we don't know after that based on the behavior of other coronaviruses. How does ibuprofen make the disease worse? So here I would say that I think there isn't fantastic data saying that it definitely does make it worse. I think the thought is that there's inhibition of COX-1 and COX-2, which are important in generating some compounds which are protective to the lung. And so it could be that that might lead to, less protection of the lung, but this is me speculating. And I think that when I last checked, it seemed like there was not solid evidence for or against use of NSAIDs. I think the initial studies for that had come out of France, but to be honest, I haven't read them. So I'm not sure what they say. Okay, Michael O'Krent says, is there a known difference between the severity of the comorbidity between type 1 and 2 diabetes? Also, how well diabetic patients have managed their blood glucose affect the outcome? I do not know the answer to this question. I think, hopefully there is some literature out there, but I don't know. Linda Cohn says, does blood type affect how someone experiences COVID-19 symptoms? I also don't know the answer to that, but there are a lot of good questions here. So anyway, thanks for the question, Linda. Jenna Grady says, curious about the impact of the virus on the kidneys. I've been reading about many hospitalized patients having kidney failure and needing dialysis and resultingly not enough dialysis resources. Yes, definitely. I mean, I've definitely been reading that there has been an increased need for both continuous dialysis and for normal dialysis, both in patients who are intubated and not intubated. Certainly kidney failure makes the disease course worse, but it seems like many people who didn't have kidney failure before are getting it. One speculation I had read suggested that there may be small blood clots which are injuring the kidney. So there seems to be a lot of fibrinolysis in some patients with COVID-19, and so maybe there's so maybe that's affecting the kidney. It could be that there's also an impact of infection of cells in the kidney, and there may be a direct toxic effect on the kidney that way. And then a third potential mechanism is the muscle damage. So some people with COVID-19 have really high CK levels, and that can cause a condition called rhabdomyolysis, which basically injures the kidney through breakdown products of muscles. So those are three theories. I'm not sure what the answer is. Okay, Dora, sorry, another question. What type of test is being used in South Korea or other countries where large-scale testing was made available successfully? They have, I think, mainly relied on the PCR-based tests that look for viral RNA. And I think they may also be using antibody testing now. Mark Takano says, can you say anything about GI symptoms? So I would say that there's some really good studies in MERS of the GI symptoms there, because that was more prominent. So both SARS and MERS seem to have had some fecal-oral transmission. Sorry, let me just check the chat for a sec. Oh, yes. Yeah, so it is possible that I will follow up with some of these later, but I can keep going for a bit. So in MERS, it does seem that you can actually have infection of gastrointestinal cells, especially enterocytes, with the MERS virus, and then that creates new infections. And for SARS, there was a case of infection of people in the same apartment building because there was a defective plumbing system, and then there were these plumes of virus that were being spread throughout the building, and people didn't have contact in any other way. So that was a case of proven fecal-oral transmission. In terms of GI symptoms and COVID, as I said, I don't think that people have detected viral RNA in stool, but and also some studies have found live virus in stool, but nobody's proven that there's been transmission from that. And people have found infectious virus in stool from people who had diarrhea, and also from people who didn't have diarrhea or any GI symptoms. So it doesn't seem to be a one-to-one correlation, but there is a thought that, certainly some people do present with GI symptoms and not respiratory symptoms. So perhaps that's due to infection of cells in the GI tract. There's also detection of virus in those GI cells. So yeah, there's been some work done, but question not answered yet. Andrew Ross, do you have a sense of the false positive, false negative rates of each of these tests? So for the RT-PCR for RNA, the sensitivity is usually around 70%, which is really not that great. So that essentially means that a lot of people may be getting false negatives. So that's a problem. And then the specificity is also not perfect either. But the specificity is higher than the sensitivity. For the antibody tests, once again, they come up a little later. So there's some biological missing of cases. And I'm not sure about the sensitivity and specificity of those particular tests off the top of my head. But I'm sure there's more information available online. Also, I think that information may be available on the medical student curriculum. Catherine Eldred says, what kind of cross-reactivity will there be to non-COVID-19 antibodies in these assays? I think a very important question. I don't know if it's known. Hui Li says, is it possible for people who have recovered to get reinfected? I think I answered that in the presentation. Mariana says, what's the sensitivity, specificity? Oh, we know that, I just said that. Lauren Spessiner says, yeah, I think I answered that in the presentation about how long antibodies last. Is the time, anonymous person, is the time to developing a treatment shorter than the time needed for vaccine development? Yes, I would say the chances are that developing a treatment will take a little less time, just because I think the last time I checked, there were over 3,000 clinical trials registered with the World Health Organization clinical trials database. So, and a lot of them have been recruiting very actively. So hopefully we'll be able to come up with better treatment guidelines in the shorter term. So not a year, so probably more on the order of weeks to months. The numbers I've been hearing for vaccine development, because there are multiple steps, including safety, efficacy, and everything. So first you need to see whether it's going to cause a reaction, then you have to see if it makes good antibodies, and then you have to see whether it actually prevents infection. And so each of those steps takes time, and even though everything's like trying to be fast-tracked, we certainly don't want to vaccinate everybody with something that can cause problems down the line. Okay. Heard there have been problems with poor antibody tests on the market. Do you know why this is the case? Jeffrey Smith. I don't know the answer to that. Lauren Spessiner, why would azithromycin cause the other treatments to work better? I also don't know the answer to that. I'm not sure. One potential issue is that both azithromycin and hydroxychloroquine and chloroquine can cause QT prolongation. So in combination, that's more of an issue, but I'm not sure why it would make it work better. One thing that people do see occasionally is superimposed bacterial pneumonia on top of the viral pneumonia that people get from SARS-CoV-2. And so in that case, azithromycin would hopefully work against the bacterial pneumonia, and that may be helpful in some patients. Thank you for Carolyn for helping. Okay, Andrew Ross. What do you think part of the reason for chloroquine's ineffectiveness is that it only blocks one of two possible pathways for the virus to enter cells, or is it probably much more complicated? Yeah, I think that is likely to at least be part of why it may not be as effective. So another thing that chloroquine does is that it sort of, it can also interfere with the acidification of endosomes in immune cells. And that's, those endosomes are important for neutrophil defenses as well. And neutrophils can cause a lot of organ damage when they're trying to fight off an infection. So, so those medications also seem to have some kind of an anti-inflammatory activity. So that could be why that might be working more. But regardless, it doesn't seem to be having a magical effect at this point. Jenna says, can you explain the mystifying adverse effects of steroids on COVID-19? No, I wish I could, but I don't know why. Anonymous, are there any thoughts or consensus on which vaccine approach, chimeric versus inactivated versus subunit, might be most promising given the way the virus works? I will defer to the later talk in the COVID-19 night school. So tune in for Carolyn. When would we get first results of clinical trials for drugs? I said that, so hopefully weeks to months. Vaccine phase 1, what does that mean? How many phases are there? So there's 3 to 4 phases. So there's 3 phases until approval, and phase 4 is monitoring after something is released. Phase 1 is safety, phase 2 and phase 3 together. So phase 2 is like, does it create the intermediate endpoints that you want? And phase 3 is it actually working? Yeah, you basically don't want to put something into people that's going to hurt them. So that's the first stage. Brooklyn Hunt says, is there any evidence that variations in self-major MHCs gives heightened immunity to some people? Additionally, is there any information on immune waning post-infection? So I think I covered the immune waning post-infection kind of MHC. I would imagine it does affect it. I don't know of any evidence though. Vasti, I think this is so if this is Tamara, she translated some of the curriculum into Spanish, so thank you very much for listening. Okay, what is the impact of this high percentage of asymptomatic cases in a population? Yeah, I think that would increase transmission quite a bit. So it also means that social distancing and these other measures are quite important, even if people think that they're not infected, because they may be, and they may be interacting with people who are infected and don't know as well. What Dora Sari says, what is the main path asymptomatic people transmit the virus? I would imagine talking or fomites. Unsure. Anonymous, if the immunity wanes over time, does that suggest that a COVID vaccine probably wouldn't be long lasting? Yes, if it wanes over time, then people may need to get the same vaccine multiple times. What is the sensitivity? Oh, I think I answered that. Surya Falkenberg, could a vaccine that uses multiple attack strategies on the virus be more effective or last longer? Hopefully, but once again, if there is this phenomenon of antibody-dependent enhancement, then maybe that wouldn't be a good idea, but I'm not sure whether that's occurring or not. Eric Yam says, what is the likelihood of a second wave in the fall of 2020? There is a great paper by Stephen Kessler, which came out, I think today or yesterday, that has a lot of modeling data that looks at timing of outbreaks based on a bunch of different parameters, like what social interventions are used and how seasonality affects the virus and lots of things. So I would recommend checking that out. So it's Mark Lipsitch, Jonathan Grada, and Stephen Kessler. Linda Cohen says, why are children not as severely affected in general? Once again, I'm not sure, but there is literature out there. Sharik Syed says, how does Abbott test kit for detection work? So that is one of the isothermal nucleic acid tests. So basically what it does is, without shifting temperatures, so PCR test has enzymes that work at basically 3 different temperatures. And so it needs to be in a cycler that goes from a cooler temperature to a middle temperature to a warmer temperature to allow each step to work in sequence. So you can get multiple rounds of amplification of the sequence that you're interested in. And more recently, there's been development of several methods where all 3 enzymes can work at the same temperature, so you don't have to move it around. And so that can be performed in a water bath that's put at the right temperature, or another heater that just keeps it at the same temperature. And there are a couple different methods for that. So I won't go into more detail than that, but that's sort of the general idea. Krish Bhatt says, can you speak to some of the risks for pregnant people? I did not actually say that. I think I will defer to other guidelines which are available. There's actually a section on this in our Module 1 curriculum, but as I said, it doesn't seem like there's mother-to-child transmission during pregnancy, but there have been cases of newborns being infected, potentially being infected by the mother, like shortly after delivery. Yeah, so I mean, there are some questions about what's going on, but I will defer to the other sources. Okay, if the BCG vaccine is found to be useful for prevention, would that mean that prior TB infection is also beneficial? So that actually has been studied, and not with many people yet, but a small study with, I think, 9 people or something who had TB, some who had recovered from prior TB and some who had current active TB, suggested that those people had a quicker progression to severe disease and worse outcomes than people who did not have TB or had not previously had TB. So with this very small study, I would say that probably prior TB infection is not beneficial. And that is an interesting question of why BCG would be helpful and TB is not. I could get into that more having studied TB, but in this forum I will not. Okay, could HIV PrEP be effective at COVID-19 prevention? Possibly. Some parts of PrEP affect proteins which are present in HIV and not in coronaviruses. So I would imagine those probably wouldn't work, but protease inhibitors are being tested, like lopinavir or ritonavir, and that's a component of antivirals that would work theoretically against both HIV and coronaviruses. Truvada, I'm not sure in particular, but some antivirals work for some viruses and not others. Dora, again, many questions for Dora, sorry. Long-term non-severe damage in the lungs for patients with milder symptoms. I think people don't know the answer to that. I think there are some anecdotes that this may be the case, at least in the short term, but it's possible that that will resolve after time. Is the receptor already identified from SM-OMASH? Yes, it is ACE2, which is involved in the renin-angiotensin system. Anonymous, if a person has HIV and is on antiretroviral drugs, is there likely to be a benefit against coronavirus? I think I answered that already. But definitely, if somebody is on medications, talk to a doctor before switching them up. Okay, Mauricio, hi Mauricio, says, Abby, comorbidity. Is there any data on whether some issues, say respiratory problems versus diabetes, are worse than others when dealing with COVID-19? So I think I have that on a slide. Let's see if I can find it. Yeah, so here's just a very basic infographic, but you can see that the death rate for cardiovascular disease, like broadly defined as 10.5%, diabetes is 7.3%, chronic respiratory disease is 6.3%, hypertension 6%, cancer 5.6%. So yes, some things are better or worse. Okay. Jiri Anand says, what are the main differences in mechanism of infection between SARS-CoV-1 and SARS-CoV-2? Can this be attributed to differences in their genomes? Yeah, so it turns out both of them use the same receptor, which is ACE2, and the same protease, which is TMPRSS2. And then there may be differences in the types of cells that are being infected. I think the early studies suggested that they had a similar tropism, but I think that still needs to be more studied in detail. One thing that's actually pretty relevant between the two is that SARS tended to be most infectious when people were symptomatic already, whereas COVID seems to be infectious in people who are not symptomatic and before they're symptomatic. And so that has a big implication for the spread of the diseases, because somebody's already really sick, they're probably not going to be out hanging out with people. So I think that's one reason why SARS was relatively self-limited, even though it was a much more fatal disease than COVID-19 is. So that goes in the whole theory that the viruses, in order to spread, need to hit a sweet spot between spreading and getting people sick, right? Because if people get too sick, then they're not going to spread very well. Okay, what's the latest on the effects of climate on transmission? Are RNA viruses sensitive to solar UV? They do seem to be effective to like high doses of UV, but I don't know about solar UV. Climate, people are still debating whether it's likely to get better in the summer or not. Certainly many countries with warm climates have been having a fair amount of COVID, so it doesn't seem like nobody can get it if it's warm out, but I think that's still being studied. Any basis to think that, I'm sorry, I'm going to skip. Oh, we're almost at the end. Yay. Okay. Is there any basis to think that the genetic differences between various nationals may have an impact on how exposed they are to the virus? I have no idea. I don't know the answer to this question. Any information about preventing cytokine storm? Yeah, I think that's the hope with some of these medications. I'm not sure about non-medication based mechanisms to do this. People are testing things like vitamin C and zinc and whatever in some clinical trials as well. So there are a lot of things that are being tested, and I guess we'll see what works. Any idea about knocking out the receptor gene? I think that might be an issue because of blood pressure control, but maybe there's a way to block it so that the virus can't bind to it, but it can still work. Is there anything that can break down the structure of the coronavirus? From Oscar, age 8. Thank you for being curious about science. That's awesome. Yeah, so the structure of the coronavirus includes an envelope, which is made out of like fatty stuff, a lipid bilayer. So soap can break it down. There are also, I mean, probably it could be cleaved by things that cleave proteins, like proteases. I don't think that would be a great treatment because it would also break down other proteins unless it was specific. And the immune system can break down viruses. So a lot of immune cells can eat up viruses and get rid of them. So my favorite cell, the macrophage, can do that, as well as some other immune cells. But they have to avoid being infected themselves. And sometimes the virus is replicating faster than the immune system can deal with it. Okay, I've reached the end of the questions. Thank you guys so much for tuning into this session. And yeah, thank you, HGSU-UAW.
Thank you, Abby. That was amazing. A lot of stamina there, answering 53 questions,
Wow, yeah.
about the science of COVID-19. Yeah, so wow, we still have 62 people here. Thanks for sticking with us through an hour and a half. Yeah, just to reiterate again, we're gonna try to put this up on our YouTube channel soon. And yeah, does anyone else have anything left to add?
Seems like somebody's raising a hand.
I checked.
It's been there a long time.
Yeah, I tried to check in with them. No response yet.
Okay.
Cool.
I haven't been looking at the chat at all, so I guess I'll have to look at that later.
No, I think Camille did a great job of transferring any questions from chat, so hopefully we didn't miss anybody there.
Yep. Should have gotten everyone, unless Carolyn or someone else answered for you.
Well, thank you so much, Abby, for sticking around so long to answer questions too. That was wonderful.
Yeah, no problem. So I would just encourage you, if you're still curious about this, to check out the curriculum. We are keeping it updated. You know, it is written for people in medical school or in the medical field, but I think parts of it would be more broadly accessible. So, so I definitely encourage checking that out. And if you have other questions, then you can let us know, and I will do what I can to answer them later. But thank you all, and I'm glad everybody is so curious about this disease, and stay safe, and, you know, try to stay home as much as possible.
Okay, hope to see a lot of you next week for Henry's talk. We'll be sending out information about that. There's some pre-assigned reading, which is exciting. It's gonna be a slightly different format. But yeah, look forward to seeing everyone again.